Let's do this. You all are going to love research. And the way we break it down, trust me, you are going to enjoy it. Okay. I had a research itch, but honestly, during my NPTE, I dug into research. I made myself open to learning whatever I know about research. And now I can say that, okay, I love research. Okay. I want you all to be at the same place. So, yes, we are going to love research. Awesome, Philip. That's great. Okay, let's start with the very base of research is about what is an independent variable, what is a dependent variable. Okay, 1 minute. Okay, yes. What is an independent variable? What is a dependent variable? So let's start with this independent variable and dependent variable. Now, independent variable is what? Tell me, independent variable is something, it's independent, okay? So it's like a treatment. Now, yes, it's something that does not change. Very good. So independent variable, if I have to give you the definition, I will say it is a factor that brings about a change in the dependent variable. So independent variable itself cannot change, but it brings about a change in another variable that is a dependent variable. So your treatment or your intervention is always going to be your independent variable. I'm going to give you examples. So hold on. Okay, so your treatment or your intervention, that is always going to be your independent variable because a treatment or intervention does not really change, but it can bring about a change in the dependent variable. Okay, now your dependent variable is always going to be your outcome. That means if it's your range of motion, if you're giving a modality to improve the range of motion, then your range of motion is what is going to change, right? The outcome is going to change. The pain on the VAS scale is going to change. Your range is going to change. The scores on your Berg balance scale are going to change with an intervention. So what is going to change? Okay, a change or a difference that has been brought about by the independent variable is a dependent variable. So independent variable is something that is constant, does not change, but it brings about a change in the dependent variable, whereas a dependent variable is something that changes when the independent variable is manipulated. So something that changes is called as a dependent variable. Something that does not change is called as an independent variable. Now, if for example, if I tell you to study the effect of cryotherapy on pain to study the effect of cryotherapy on pain, what is the independent variable? What is an independent? What is the treatment? It's going to be cryotherapy. What is the outcome? The outcome has to be pain. That is, it has, let's say it's measured in your numeric rating scale or your visual analog scale. So that's going to be your outcome. That's going to be your dependent variable. Let's say to to study the effect of aerobic exercises in improving weight loss, in helping with weight loss. So what is the independent variable? Aerobic exercises. What is weight loss? Weight loss is going to be your dependent variable. Like your weight is going to be the one that's going to change. So that's going to be your dependent variable. Then let's say contract relax technique helps in improving the range of motion of the knee. What is your independent variable? Contract relax technique. What is a dependent variable? Dependent variable is going to be your range of motion. Now, along with the dependent independent variable, you have something which is called as an intervening variable. What do we understand by the term intervening variable? Intervening variable is something that cannot, like it's something whose effects you cannot control. So let's say if I want to see how high can I jump, okay, I want to see how high can I jump. But if the patient is already tall, can you control the effect of the height? No, right? So you cannot control. So intervening variable is something that you cannot control. Correct. If the patient is anxious, he may not perform well. That's something you cannot control. So for example, hard work. Okay, if you work hard, you're going to pass the NPT. But sometimes you work really, really hard, but you get really anxious on exam day. Can you control that? No. So your thing was just about hard work and passing the NPT, but you could not control the anxiety out there. So something which you cannot really control is called as your intervening variable. Is that clear? Everybody knows what is independent variable, what is dependent variable, what is intervening variable. Good? One topic done. Let's keep ticking the topics that we are getting done with research, okay? Now, the next topic is going to be your types of data, okay? The types of data that we have in your, types of data that we have in research. We start with nominal. Nominal type of data is it's just like your, I can say it's the classification of my variables into mutually exclusive categories. So nominal is all about just classifying into mutually exclusive categories, like for somebody like you know, possessing common set of characteristics. So for example, I could say blood group A, I mean, dividing into 4 categories, blood group A, B, O, AB negative, right? Or I'm dividing into 3 categories, blonde hair, brunettes, and black hair. Or I'm dividing into males, females. Or I'm dividing into types of arthritis, rheumatoid arthritis, osteoarthritis, or male, female. So when I am just dividing it into mutually exclusive categories, that is called as nominal. Okay, so when the data is just divided, is the data ranked here? Do I have a rank? Do I have an order? Nothing. Okay, I have nothing. I have just divided them into mutually, I have just joined them into mutually exclusive categories. Okay. Now, it's not ordered, it's not ranked. Okay, it's not ordered, it's not ranked. So this is your lowest level. Okay, so this is your lowest. Nominal is your lowest level of data. Okay, if they ask you which is the lowest level of data, that's going to be your nominal. It's not numeric, nothing. Okay, then we have your ordinal. So think about nominal is the bottom step. Then you have your ordinal. Now, what is different in ordinal? Ordinal is going to be ranked. Okay, ordinal is going to be ranked, or it's going to have a number. But is it going, so it's going to be ranked, it's going to have a number. What does it not have? It does not have equal intervals. This is very important to remember so that you don't make a mistake in choosing ratio and ordinal. A lot of times we end up making mistakes between ordinal and ratio. So we have to remember that it is ranked, it is ordered, but it does not have an equal interval. What do we mean by that? That means I am just ranking something. So let's say all my outcome measures like MMT, I have a grade of 1, 2, 3, 4, 5. Specificity, I have a grade of 1, 1 plus 2, 3, 4, 5, right? So I have just ranked them. I have just ordered these outcome measures. Can I say there is equal interval between MMT of 3 and 4 and the equal interval between MMT of 4 and 5? Can you say that whatever strength is there, that's same? No. Same way for any outcome measures, you cannot say that there is an equal interval. Okay. So you cannot really say that there is an equal interval. Okay, that is very important here. So your data is going to be ranked. It is not going to have equal interval. So what is an example of your ordinal? All your outcome measures. Okay, so your MMT, your VAS scale, your Trinity-Poma scale, your BERT scale, modified Ashworth scale, FIM grading, all of this will become ordinal because it is ranked, but it does not have equal intervals. Clear? Now, the third one, now we will be doing parametric, non-parametric later, but usually when your data is nominal and ordinal, the type of test that you will be able to use will be a non-parametric. Okay, the type of test that we use when it is nominal and ordinal data is a non-parametric test. Now, the third one is going to be interval. Okay, we have your third one that is called as your interval. Now, how do we describe interval? Interval is something that is ranked, and now it also has equal intervals. So think about step number 3. So from it's like you're going on getting better. So first was just categories. Second was now you are able to rank them. Now third one, you're able to rank them, and you're also you're also having equal intervals. So for example, let me give you the example of temperature. Okay. Now, along with equal intervals, okay, so before giving the example, it is having equal intervals, but it has no true zero. What do we understand by equal intervals and no true zero? What do you mean by zero? Can I say zero means nothing? Zero actually means nothing, right? Zero. But what does it mean by no true zero? No true zero means that zero is not actually zero. It means zero has a meaning here. When they say no true zero, that means zero has a meaning. For example, temperature. When I say it is 0 degrees Celsius or 0 degree Fahrenheit, let's say I'm saying it's 0 degrees Celsius, 0 degree Fahrenheit, does it mean that there is no temperature or there is a very cold temperature? It's a very cold temperature. That is the meaning of no true zero. That zero does not actually mean nothing. Zero has a meaning here. Okay. So interval has very few examples. Okay. So interval means there is equal intervals. Along with equal intervals, you have no true zero. Your temperature in your Celsius, okay, your temperature in your Celsius and temperature in your Fahrenheit, both of them are examples of your interval, because both of them, the zero indicates actual cold temperature, does not indicate no temperature. Okay, now that is your, and then what do I mean by equal intervals here? So can I say there is equal interval between the temperature 0 to 1 and 1 to 2? Same temperature difference, right, between 0 to 1 and 1 to 2. And that's equal interval. Another thing, let's say time. Let's say time. 1 hour has 60 minutes, right? 1 hour has 60 minutes. Now, when you see that the interval between 1 to 2, 2 to 3, 3 to 4, each one of them has 60 minutes, right? So can I say time has equal intervals? And it also has no true zero. Can I ever say there is zero time? So can I consider time also as an example of interval? No true zero as well as equal intervals, right? Okay, so this was your third. Now your highest level of data, okay, your highest level of data is going to be your ratio data, okay, that's your highest level of your data. That's going to be your ratio. Now what does ratio indicate? Ratio indicate it has equal intervals. Now it also has a true zero. So that means, you know, it has an order, it has an equal interval, along with it has a true zero. So can I say all these things like range of motion, blood pressure, height, weight, force, velocity, speed, nerve conduction velocity, everything like height, weight, BMI, all of this is having a true zero? Do you agree? All of this has a true zero, all of this has equal intervals. A lot of times somebody asks me, why is VAS not a ratio, but why is VAS an ordinal? Because VAS has a true zero, but does it have equal intervals? Can you say the pain between 2 to 3 is the same as pain between 3 to 4? That is why it is an ordinal. Same thing with height, weight, blood pressure, all of that has equal intervals, right? You know that there is equal intervals between this, whether it's distance, whether it is speed, anything has equal intervals, which is why force, velocity, speed, nerve conduction velocity, distance, BMI, height, weight, range of motion, all of this is an example of ratio. Okay, quick summary. Nominal is just mutually exclusive categories. It is the lowest level, just dividing them into categories. Ordinal is you rank them. Now you're ranking them, but it does not have equal intervals. So all your outcome measures will come under ordinal. Third one is your interval. Interval is something, okay, your interval is something which is having an equal interval, as well as it is having an equal interval, as well as it does not have a true zero. So temperature in Celsius and Fahrenheit, as well as time, that's going to be your interval. And ratio is equal intervals along with true zero, height, weight, BMI, distance, force, velocity, speed, etc., etc. That's going to be your ratio. Makes sense? Everyone clear with the level of data? Your scale, your balance scale will be ordinal. So data has to, if you're saying balance scale, like you're just testing the balance with the use of Berg balance scale or anything, that is going to be your data. Okay, same thing if you are using like any number or any ranking, that's going, let's say if a scale is using, if a scale uses 1, 2, 3, 4, that scale is going to be more like your ordinal. But if a scale uses good, bad, fair, what is that scale now? Nominal, correct, because it's categories. Yes, APGAR is also ordinal because again, it is based on your ranking or your numbering. Okay, everyone clear now? Awesome. Number 2 done, 2 topics done. Independent, dependent variable and your types of data. Okay, good job. Everyone clear so far? Level is going to keep on increasing, so keep making sure you're attentive. Okay, all right. Now we come on to validity. Okay, validity is, okay, what is validity? What is your validity? What does validity indicate? Excellent. So it is your accuracy. Always remember the keyword. Validity is your accuracy. It's the degree to which a test accurately measures what it is supposed to measure. So when it accurately measures what it is supposed to measure is going to be called as your validity. Always remember accuracy is a key word for your validity. Okay, accuracy is a keyword of your validity. Now the next thing is your types of validity. Okay, types of validity. Types of validity. The first thing, let's talk about before that, let's talk about what do we mean by internal validity and what do we mean by external validity. Okay, what do we mean by internal validity and what do we mean by external validity? Let's say it's basically internal validity is the degree to which the whatever changes are there in the dependent variable is because of the direct result of your manipulation of your independent variable. I know it sounds Latin and Greek. I'm going to explain it. Okay. So let's say if you're doing aerobic exercises to lose weight, that's your internal, like let's say internal validity, aerobic exercises helps to lose weight. So in that patient, in that subject group, okay, in that group, whatever they're losing weight because of exercise, when the results are only within that subject group, that's called as internal validity. So the person is losing weight because of your aerobic exercise. So that's your independent. So that's your internal validity. So the changes in the dependent variable are the direct result of your manipulation of your independent variable. That means I am manipulating my independent variable. That means I'm doing more aerobic exercises. If I'm doing more aerobic exercises, I can see the result in my weight loss. So when it is only when we're talking about the validity of only that particular study or that particular subject, that is called as internal validity. Okay. But external validity is whatever results that I get, I did a good study and I got that my aerobic exercises is helping in losing weight. If I am able to generalize this result to my entire population, let's say after doing a study, I can generalize it that in no matter what population or in a particular population, if you can generalize it, that everybody from this population, when they do aerobic exercises, they are going to lose weight. That is external validity. So for example, obese population, aerobic exercises helps in losing weight in the obese population. So whatever study that I did, if I can generalize it to that entire population, that's called as external validity. So now internal is just in your own subject and in your own study, and external is your whether you're able to generalize your results or no. So if let's say if your study is that good and you are able to generalize your results to your entire population, you can say that this study has a high external validity. But if your study is not, like maybe it's not really having that population that is to be studied, it has like just let's say you just have volunteers or something is there where you cannot generalize the results to your entire population, you can say that this study has low external validity. Are you getting it? So external validity is when you can generalize whatever results you get in your study to the entire population, that is going to be called as your external validity. So if it's high, that means you can generalize your results. If it's low, maybe you cannot generalize your results there. Okay. Just getting your question, Philip, is the study design good? Internal validity, can it replace? Perfect. Yes. So is your own study good? That is your internal validity, right? So yes, if my own study is good, I got my results. Yes, my study has a high internal validity. Can I replicate the same results in somebody else from somebody else in the population? Then I have a good external validity. Okay, so that's a very good example, Philip. Okay, so these are your two types of validity. One is an internal validity, one is an external validity. So your own study design, internal validity. When you are able to replicate the same results in the population, that is your external validity. Okay, your next validity is going to be your face validity. Now look at the name, face validity. Looking at me, do you think I can teach? Just answer me that way. Looking at me, do you think I can teach? You can say no. If you think that I can teach by just looking at me, then it's going to be like I have a high face validity. If looking at me, you're like, I don't think so, this woman can teach, I have a bad face validity. That's what face validity is. Okay. So whether it's your own perception, right? Some of you all said no. So that means according to you, I don't have a good face validity. But some of you all said yes. So then according to you, I have a good face validity. So face validity is something very subjective. It's the assumption of validity based on the appearance of an instrument. Okay, here I was the instrument. But it's basically just how accurate it is, just basically by the appearance of it. So for example, if I look at a goniometer, looking at a goniometer, can I, like, do I think that it's going to measure the range of motion? I think yes. So I feel that the goniometer is going to have a high face validity. Do you all know what is an inclinometer? Inclinometer is something that you use to, measure your lumbar and cervical range of motion. Yes, it has a fluid. Looking at that, I don't feel that it can measure range of motion unless and until someone shows me how to do it. So that would, for me, that it does not have a good face validity. Right? So understand. So when you're just making an assumption of the validity by just its appearance, it's going to be called as a face validity. So it can have high if you feel that, okay, it can do something, and low if it does not. So do you think this is a very accurate form of validity, or it's not a accurate form of validity? It's not really an accurate form of validity. It's not an accurate indicator, but still it is going to be needed. Why is it going to be needed? Because if you don't believe, if the particular instrument that you're using does not have a face validity at all, like you don't believe that, you are not going to have the faith in the experiment. Some face validity is something that is required for the initial screening of the instrument. Like psychometrically, like, you will feel that, okay, this is not psychometrically correct. Like you're going to be like, what is this going to do? Okay, so you won't have the faith in the experiment. So that is why it is necessary to have a face validity just to initially screen the instrument. But it's not a very accurate form of your validity. Okay, everyone understood what is face validity? Now, content validity. Okay, what do we understand by the term content validity? Content validity indicates basically the ability of the, it's basically the ability of the test to measure the entire content. So it's basically to measure the entire content. Giving you an example, if you want to measure pain, okay, let's say you want to measure pain, and you have a VAS scale, okay, where you can measure pain. So if you're measuring pain on a VAS, you're able to identify all the physical aspect of pain, that, okay, this patient is experiencing so much pain. But if for same thing, for measuring pain, if I use a McGill pain questionnaire, do you all have an idea what is a McGill pain questionnaire? It's a questionnaire. Okay, McGill pain questionnaire is a questionnaire with a lot of aspects of pain. They're asking you multiple questions about physical aspect of pain, emotional aspect of pain, psychological aspect of pain, everything. So which one do you think covers the entire content of pain? Is it VAS or is it McGill pain questionnaire? It's your McGill pain questionnaire, right? So that is why content validity is the degree to which the test measures the intended content area. So even VAS is going to have a content validity. I don't say VAS does not have, but if I am put VAS and McGill, that means I can say that McGill has a higher content validity as compared to VAS. Why? Because it's measuring the entire intended content, right? I'm measuring all the aspects of pain. So when your test is basically measuring the content area that it is supposed to measure, that's going to be your content validity. Does that make sense? The next type of validity is your criterion validity. Okay, the next type of validity is your criterion validity. Now, this criterion validity is divided. It's divided into concurrent validity and it is divided into predictive validity. So you have concurrent and you have predictive. So what is concurrent validity? Concurrent validity is the degree to which your scores on one test are compared to your other test, which is a gold standard at the same time. Now, what does that mean? If, for example, I have introduced a new test in the market, okay, for ACL, let's say there is one test that I really want to like basically bring it about that, okay, this test is also very good. Now, how do I make sure that I can do it? So that's for that, I have to compare it with the gold standard. So what is my gold standard special test? What is my gold standard special test for ACL? Lachman's, right? So what I'm going to do is I'm going to do the that new test and I'm going to compare it to the Lachman's at the same time. If both of them are positive, can I say that this my new test is good, it has a high concurrent validity? Yes, because the results are going to be almost same. If my Lachman is negative, but my new test that I'm trying is positive, does it have a good concurrent validity? No. You can also use MRI. This is just, I told you the gold standard. You can use any gold standard. So let's say you are testing a new test, you're comparing it with a gold standard that is an MRI. So you took a patient's MRI and you're performing the new test that you've done. You take the MRI and you do the new test. So the new test is positive and the MRI is also showing the tear. That means that test is good and that test has a high concurrent validity. Makes sense now? Whatever, you can compare it to the gold standard at the same time. For example, you are an excellent clinician. Okay, you're an excellent clinician, but you are deciding to get married and you decide to move. Okay, let's say you are working in a clinic and you're going to get married and you're the best clinician, but you want to move. So now your clinical director is really worried and it's like, okay, I need to replace somebody as good as you. What are they going to do? They're going to give a standardized test solved by you. So you are going to solve a test and the new hire, the person whom they hire, that person is going to solve a test and the result of their test is compared to your test because you're the gold standard. They want to hire someone like you. So the results on your test are going to be compared with the results on the new hire test. And if they're equal, that means they have a high concurrent validity and it is good. It's like a green signal to hire them, right? That's your concurrent validity. Makes sense? So when you are comparing it with the gold standard, at the same time, that is very important. At the same time, if you are comparing it, that's going to be called as a concurrent validity. Good, everyone good with what is concurrent validity? Now, what is predictive validity? Predictive validity is the scores on the test are related to scores on the other test given at a later time. So what are they doing? It's something like prediction, aptitude test, GRE test, your GPAs. So if you give an aptitude test, you are predicting, right? You're giving a test that's an aptitude test. It is helping you predict your future outcome. That, okay, this person is going to, has more potential in healthcare, right? Or if you give your GPAs, if your GPAs are a 4.0, they're going to be like, okay, this patient is this person is going to go into Columbia or this person is going to go to Harvard, right? So based on that, so basically when you are taking a test to predict a future outcome, that's called as a predictive validity. Okay, so okay, just taking up your question, Crystal, it's like a patient performing Lachman's and requesting an MRI and you could do that. Yes, it's something like that where an MRI is maybe requested later and you did a Lachman and you diagnosed it as an ACL tear, but even later on when they do MRI, they are going to get it positive. That's correct, right? Same thing if you give a aptitude test, you know that, okay, later on you're going to be, if you go into healthcare, that's going to be like your aptitude. Okay, another example of predictive, we just gave one that Crystal said that if you perform Lachman's test and you said that the patient is having an ACL tear, it is used to predict the future outcome. Let's say when you do an MRI later on, that will also show a tear. Or let's say if you are giving a GRE to enter into a college, if you get a GRE score, I don't know what is the score, but if you get a good score on the GRE, you already have predicted that you're going to get into a good college. Okay, so that's basically your predictive validity, basically something to predict the future outcome. Okay, you're giving a test to be compared later. So that's going to be your predictive validity. Okay, and one more validity that you have is a construct validity. What is a construct validity? Construct validity is something that is a little complicated. I mean, not complicated, but it's something that is hypothetical. So it is basically the degree to which the test measures what it is supposed to measure. Okay, so the test is going to measure what it is supposed to measure, but that supposed to measure is going to be very hypothetical. So when you're trying to measure behaviors, you're trying to measure like psychological things, you're trying to observe their behavior, or basically you're trying to measure their ideas, hypothetical ideas, all that is construct validity. So whatever test, the degree to which the test is able to measure a hypothetical abstract, something abstract, that is basically your construct validity. It's difficult to visualize construct validity, but it is what it is supposed to measure, but in a hypothetical manner. So basically your ideas, when someone tells you to measure ideas or behaviors or psychological thinking or anything, that's going to be your construct validity. Okay. Construction is how the study is built, correct? So study for the best sports drink sponsor has a bad construct validity. Yeah. So basically it's make notes about level 4 RLA patient. You could say it that way, but it's building up like your construction, correct? It's how it is built. And it's also something that you cannot really measure objectively. It has to be like an idea, okay? So it's just idea when someone's promoting something, or like someone's behavior, or someone's just ideas or abstract thinking, logic, all of that. When you're basically your test is measuring that, that's your construct validity. Would it be like a patient saying they are in 10 on 10 in pain, but straight faced and seem fine? So that if you are basically trying to measure, then you could say that. So if you are trying to measure their pain, when, like, just by looking at their face, okay, so the patient tells you is in a lot of pain, but just by that you are trying to measure their pain. You don't believe they are in 10 on 10 pain, but you are trying to a test, like you are giving a test that is able to measure that hypothetical pain that they're experiencing, or a malingering. That is a construct validity. So like basically measuring their fear, like that's construct validity. Or measuring their ideas, what is going on in their head, that is construct validity. Okay, so when you're able to measure something abstract or behavior or ideas or fear, that's going to be your construct validity. But it is still going to measure what it is supposed to be measuring. So all your tests, like, I don't know if you guys have heard about the test, fear avoidance behavior, the FABQ test. Okay, there's a test, yes, your FABQ, or your quality of life, right? Your quality of life, your FABQ. So all this is, what is it measuring? It's measuring your quality of life. It is measuring your fear. So these are not something that is like quantifiable, right? All this is mainly abstract, or it is just their behaviors. So this is what you're measuring. So all these are examples of construct validity: quality of life questionnaire, your fear avoidance behavioral FABQ one. So all these are your construct validity. Make sense? Yes, fear avoidance behavior questionnaire. Excellent. Okay, so this is your types of validity. So remember, validity is your accuracy. You know what is an internal validity, what is external validity. Internal is your own experiment. External is generalizing it to the population. Face is just by appearance. Content is just measuring the entire content of that particular thing. Criterion can be concurrent. Gold standard at the same time. Predictive is to predict a future outcome, and construct is to measure a hypothetical abstract or fear or quality of life, or etc. Everyone clear with types of validity? Good job. You guys are doing good. Threats to validity. What do I mean by threats to validity? Okay, content validity, Anushka, I mentioned about pain. So your content validity is when you are measuring the entire content. So your VAS scale is only measuring the physical aspect, physical content of pain. That's all. That may have a low content validity, but your McGill pain questionnaire measures all the aspects of pain. That means it measures your entire content of pain, physical, emotional, behavioral pain. So that could be your content validity. And Betul, construct is something that you are able, your test is measuring what it is supposed to measure, but that whatever it is measuring has to be more hypothetical. It cannot be something what it cannot be like your muscle strength or your range of motion that you are objectifying. It has to be something like fear or depression, anxiety, or your fear avoidance. So that is your construct. Contract, there is no validity like contract. Well, this is construct validity. Okay, I think I made an error on the whiteboard. That's your construct validity. C-O-N-S-T. I can't edit this, but this is C-O-N-S-T-R-U-C-T, construct validity. Yes, that is the one. That is your construct validity is measuring hypothetical concepts, hypothetical fear avoidance, anxiety, depression. That is construct. Okay. Everyone clear now? Okay. Now we are going to go ahead and do the threats to validity. Threats to validity could be your threats to validity would be what is something that is actually causing a problem with validity. Problem with validity means what is causing a problem with accuracy. What all can affect the accuracy of an instrument? Come on, tell me what all can affect the accuracy of a test? What all can affect the accuracy of an instrument? What affects this accuracy? Carryover, good. Sampling bias. Okay, let's start with sampling bias. In my study, if I do not do random sampling is randomly picking people. We know random sampling is the best form of sampling because you are able to collect people randomly from every part of the population. But instead of doing random sampling, just for my convenience in my study, if I decide to do convenience sampling, that means whoever is available, I pick them. Will that affect my validity? Yes, that is called as a sampling bias. Okay, that's going to be called as a sampling bias. Another thing, I cannot exert control. I cannot exert rigid control over my subject or my conditions. For example, if I'm making an obese population exercise to lose weight, that's my study. But if they go home and they eat more calories than required, can I control it? Even though I say no, but if they go home and do that, I cannot control that, right? Or if I'm doing a study on a pediatric age group, pediatrics grow, kids grow, right? Can I control the developmental chain that is happening in the patient? No. So when I cannot exert rigid control over the subject or the conditions, that can also affect my accuracy or affect my validity. Okay. Then is my experimental bias. What do I mean by experimental bias? Okay. Today I'm doing a study. Okay. While I'm performing this study, I see in my head, I know that I want ultrasound to improve the range of motion. Let's say I'm doing a study on will ultrasound improve my range of motion. So when I'm measuring the range of motion, can I have a bias? Can I just like I feel that the range is more after ultrasound? You do have that, right? When you do a study. So that's your experimental bias. Okay, the expectation of the researcher, whatever the researcher expects about the result, that's called your experimental bias. That can also affect my validity. Instrumental error. Okay. Instrumental error can also affect my validity. Now, what is an instrumental error? Instrumental error can also affect my validity. So instrumental error is if my instrument is faulty. Okay, let's say my weighing scale is already measuring 5 kgs more. Is that going to affect validity or accuracy? Yes, it's going to affect. So an instrumental error will also be a threat to validity. Hawthorne effect. What do I mean by the word term Hawthorne effect? Hawthorne effect means that when someone's observing you, you're going to perform better. Okay, so the thought of that, okay, you are in a study, the knowledge that you are participating and people are observing you, you tend to perform better than what you are usually doing. Will that affect my validity or my accuracy? Yes, it will affect my validity or accuracy. Placebo effect. If you start showing, if you start showing improvement with sham treatment, let's say I'm giving ultrasound without even turning on the machine, and you start seeing improvement in range of the patient because in his head he thinks it's working, will that affect validity? Yes. So your placebo effects is also going to affect validity. Learning effect. What is learning effect? If I like administration of a pre-test may influences the post-test results. So if I've given a pre-test before, the patient has intrinsic feedback, right? When you do a pre-test, there is intrinsic feedback. The patient starts realizing, oh, I should have walked slower here. Then I should have picked up my speed here. This would have reduced my fatigue. So when he does the post-test, automatically he makes all the modifications and he's performing better. So you don't really know that the post-test is because of the actual modality that you're giving, or it is because of your pre-test. So will that affect your validity? That's your learning effect. And the last one is your carryover effect or your multiple treatment interference. So carryover effect or multiple treatment interference. What does that mean? Let's say I'm giving ultrasound to improve the range of motion. But before ultrasound, I gave heat to improve the range of motion. Okay, so I gave heat to improve the range of motion, and then I gave ultrasound, and then I'm measuring the range. So maybe some effect of the heat is still there. Okay, some effect of the heat is still there. That kind of made my some effect of the heat is still there, that made my range improve. So it's not only the ultrasound that is causing the increase in the range of motion. Maybe the heat that I gave before has caused some of the change. So this is your carryover or your multiple treatment interference, that your previous treatment's effect is getting carried over. Okay. So your multiple treatment interference, when basically two treatments are given at the same time or one slightly before the other, the effect of one of the treatment is still present. So that can also affect your validity, right? So these are your threats to validity. So what are your threats to validity? All of this: sampling bias, you cannot exert a control, your experimental bias, your instrumental effect, your Hawthorne effect, your placebo effects, your learning effect, your carryover effect. Learning effect, okay, I can explain learning. What is learning? Today, if you're giving a pre-test, okay, today you're asking the patient to walk on a treadmill and you're going to measure his heart rate or whatever. While doing a pre-test, the patient starts realizing what mistakes he did in the pre-test. So he's already learned them. So when you do the post-test, he doesn't make those mistakes and the result is automatically better. So you don't know whether your intervention has made the result better or the patient's own learning of what mistakes he had done in the pre-test made the effect better. So that is called as a learning effect. You always learn. Same thing like your NPT. Your Final Frontier Exam 1, you gave it last cohort. You scored 580. This cohort, you scored 680, but you already remembered previous questions, right? You already learned it. Some of your questions were previous. So can you gauge that is your 680 your appropriate score? No, it is affecting your accuracy, right? Same thing, that's your learning effect. Okay, and rigid control is if I cannot exert rigid control over some of the patients. For example, if I'm telling a patient to if I'm treating a patient to perform weight, like I'm doing the aerobic exercise for a patient for weight loss, okay, or while doing aerobic exercises the patient is fine, but after the patient goes home he eats much more than required, even though you tell him no. Can you control what he does at home? No, you cannot control what he does at home. That is you cannot exert a control over, you cannot exert a rigid control over your subjects. That can also affect your study results. So all these are, okay, it's not necessary it's improvement only, Dhruvi. Anything could be a carryover effect. Whatever you learn can show up in your next test. So that can affect your accuracy of the next test, right? So that is basically your carryover effect. Anything that you learn can affect. Dropout of subjects can also affect validity. That is also correct, because let's say you have a big sample size and a lot of subjects drop out. your study is not going to be that accurate because you've lost out a lot of subjects. So that can also affect the validity. Yeah, improvement of range of motion. Let's say if they have learned that, okay, maybe in the pre-test, your muscles are already stretched. In the post-test, you may have improvement in the range of motion. Anything can be a carryover effect. Okay, anything can be a carryover effect from the previous. Yes, usually for more accuracy of your study, you should be having for more accuracy of a study, you should have a random sampling and you should have a large sample size. Okay, what is instrumental error? When whatever instrument you are using is faulty, if you're using a weighing scale and the weighing scale is not calibrated well, that is an instrumental error. Okay, I'm going to come to your error. I mean, I'll tell you how to avoid errors. Okay, right now we are on validity. Is everyone clear with validity? Next topic for today is your reliability. Okay, reliability is your next one. What is a keyword for reliability? Like accuracy was a keyword for validity. What is a keyword for reliability? Reliability is your consistency. Excellent. So reliability is consistency. Accuracy is your validity. Now, when someone is consistent, that's your reliability. So the degree to which the test consistently measures what it is intended to measure. Okay, now reliability can be of your rater, that means of your researcher. Okay, you can measure the reliability of a rater and you can measure the reliability of an instrument. When you're measuring the reliability of a rater, it can be inter-rater or it can be intra-rater. So what is inter-rater, intra-rater? Inter-rater and intra-rater is basically you're measuring the reliability, that is a consistency of researchers, like the people. Okay, so inter-rater is when you're measuring the degree to which the readings are obtained for a given variable by two different raters. Okay, so example for me, okay, me and Beatrice, let's say I am measuring the range of motion for someone and Beatrice is measuring the range of motion for someone. I get the range of motion as 25. Beatrice gets the range of motion as 35. Do we have a good inter-rater reliability? No, because between two researchers, if there is so much difference in the range of motion, it is not a good inter-rater reliability. But let's say if I get 20 and Beatrice gets 21, is that a good inter-rater reliability? That's a good inter-rater reliability. Perfect. Okay. So there's no exact number, but just for NPT purposes, just for learning purposes, remember your difference in the number shouldn't go more than 5. Okay. Your difference in the number shouldn't really go more than 5. So if I say that I have 21 and then the other one is like 23, it's okay. But if I say 21 and I say 28 or 29, that's not good because the difference is more than 5. Right? So this is just for NPT purposes to see how much reliable something is. So your difference should be usually less than 5 to be reliable. For example, if I am intra-rater, intra-rater is basically the degree to which a rater can obtain same readings for a given variable, okay, when measured. So if I'm measuring the range of motion for an elbow, okay, first I measure the range of motion, second I measure the range of motion, 3 times I measure the range of motion, I get 65 degrees, 66 degrees, 67 degrees. Do I have a good intra-rater reliability or I have a bad intra-rater reliability? I have a good intra-rater reliability. But in case my range measured 65, 72, 80, then it would have been a bad intra-rater reliability. So inter-rater reliability is when you measure when the reliability is between two raters. Okay. Yes, less than 5. That's correct. Less than, for your reliability purposes, just remember the number less than 5. Okay. 5% error, that is different. Percentage error, that is with your statistical studies. We've not covered that yet. But just for NPT purposes, remember a number of 5 in order. Usually they don't give you numbers, but in case they do, then just remember 5. But most of the time they'll ask you, if you are measuring, if it's basically the reliability between two raters, it's going to be called as inter-rater. And if the reliability is measured for one rater, it's called as intra-rater. Is that clear? Inter-rater, intra-rater. Perfect. Then you have your test-retest reliability. Now, test-retest reliability is your instrumental error. I mean, it's basically a reliability of the instrument, not error. I'm sorry about that. But instrument, when you're checking the reliability of the instrument. Now, these two reliabilities, were they the reliability of the instrument? No. You are checking the reliability of the rater. That means your researcher. Here you're checking the reliability of the instrument. So there are two reliabilities that are checked for the instrument. One is your test-retest. What is a test-retest reliability? The degree to which the instrument produces the same result when you are testing it. So if the instrument is measuring 50 degrees, again measures 50 degrees, again measures 50 degrees, and when you are like over a period of time also, like, so basically on two occasions, the measure is the same. Okay, when they're measuring over two occasions, you see that there is very minimal difference. Can I say that that is basically my instrument is a consistent instrument and the reliability is high if the scores are same? Okay, so test-retest measures the instrument consistency. It measures the internal consistency of the instrument, measures the instrument stability, how good or how consistent my instrument is. Right? Everyone clear? How is intra-rater different from test-retest? Inter-rater measures the reliability of the rater. Test-retest measures the reliability of the instrument, the degree to which the instrument can produce the same rating over a period of time, like on two separate occasions. If it can produce the same rating, that means that's your test-retest reliability. Clear? The other one is also a type of reliability of your instrument. It is called as split half. What is split half reliability? You want to check how reliable, how consistent the test is within itself. So within itself, how is the test so consistent? So let's say you have a test, let's assume work balance scale, any test that you're using, okay? Split the test into two. Give one half of the test to people, okay? Then you give the second half of the test to the same people, and then you check the scores on first half and the second half. If the scores are good on the first half and the second half, what does that mean? What is the split half reliability? Good, bad? Good. That also means that the instrument is having good consistency. Internally, the instrument is all uniform. Okay, whatever test you're giving, let's say you're giving work balance, tinnitus, their internal consistency is good if while dividing the test into two. If you are dividing the test into two parts and they both parts are almost having equal scores, that means the internal consistency of the test is good. Okay, so we did 4 reliabilities. 2 were of the rater, inter-rater, intra-rater. Okay, that is inter-rater was between 2 raters, intra-rater was between 1 rater. Okay, a split half is you divide, it's not, so split half is not dividing into patient groups, Betul, you divide the test into 2 groups, okay? You divide the test, so let's say your test has 50 parts. You put one part, 25 things in a test and 25 things in another test. You're dividing the test into 2 parts, okay? And the test should have consistent scores, not the patient group. Okay, so your test is divided into 2 halves. In your split half, 1 half should be comparable to the other half. If your both halves are comparable, that's going to be increases the internal consistency of the instrument. Why are we splitting the test or the instrument? I mean, why are we splitting the test? Because you want to check the consistency of the test, right? You want to check how good, how reliable the test is. So you're breaking down the test into 2 halves. Test should be done at the same time. You can have you don't need to be done at the same time, because if you do test 1, you can give them a break and then you can do the test 2. So you can have few hours in the middle. Okay. The difference between test retest is there is no splitting in test retest. Test retest is you are measuring with that same instrument, you are measuring one time and then you are again measuring it again time if the scores are consistent on two separate occasions. That is your test retest. Split half is you are actually splitting the test into two halves. That is your split half. Okay. And there is one more. I don't think so they'll ask you that in your exam, but I'm just telling you in case you see it in any option. Alternate forms reliability. Okay, alternate forms reliability. This is a good example of your NPT. So you want to see like alternate forms. So in your NPT, you have multiple sets, right? Somebody gets set A, somebody gets set B, somebody gets set D, somebody gets set D. Do you think all sets have different difficulty level or they all have almost the same difficulty level? Same. That is why they have a strong alternate forms reliability. Okay, strong alternate form reliability. Let's say they have a question bank of 1,000 questions and 5 sets. Randomly put like those questions into 5 sets. All 5 tests. If a person is like if one patient, if a group of people is testing test A, is testing form B, form C, there should be equal scoring. Like I mean, almost similar scoring. If you're passing in test A, you should be passing in test B, C, D. That's an alternate forms reliability. For your standardized exams like the NPT, if they have multiple forms, they have to go through this reliability. The set should have a strong alternates form reliability. If they don't have, that means it's not fair for the students. Okay, that is why your sets are almost of the same difficulty. Maybe set A has few questions very easy, but has others very difficult. Set B will also have some areas that are very easy, will have some that are difficult, maybe from the different subjects, but they will have almost the same difficulty. That means that's your alternate forms reliability. Okay, again, this is not something that will ask him. They may ask. I have not seen it in any practice question yet, but in case they ask, you know what is alternate forms. Yes, NPT does not have, not if you all are taking exams on different days, you all are not going to have the same exam. Okay, good. Everyone clear with the different types of reliability? I want to talk about some errors. Okay, now there are two type of, okay, I'm not going on type 1, type 2 error. Remember, that is when I teach you about studies, we will do type 1, type 2 error. I'm still on reliability, validity. Okay, so don't confuse your type 1, type 2 errors here. I will cover that in the next class. Okay, now what I want to talk to you is about what do you mean by random errors? And what do you mean by systemic errors? There are two types of errors. One is random error and one is your systemic errors. Random errors are any random thing. So let's say if I'm tired, if I have to measure the range of motion thrice, is it possible that my second and third will not be accurate if I'm tired? Yes, right. So that's a random error. Let's say if I've hired someone new, a new grad, is it possible that they will have some errors with the PT examination? Yes, that's going to be a random error. So anything that is like a random error, I think someone's on unmute. Just a second. Please mute yourselves. Okay. So when something is random, okay, that's called as a random error. So a new grad doing an experiment, or somebody getting really tired, or some emotional problem, anything, your errors that you're making randomly, those are random errors. And what is a systemic error? Systemic error could be an error in the machine. Let's say the weighing scale is calibrated, it starts from 5 rather than 0. Rather than 0 pounds, it starts from 5 pounds. Okay, so that's a systemic error. It's an error in the instrument. Okay, now random errors, will it affect, tell me, will random errors affect validity? Will it affect accuracy? Will random errors affect validity? Of course, it affects accuracy, right? Will random errors affect reliability? Random errors happening, will they affect the consistency? Yes, of course. Maybe you are not consistent. Maybe one time you are tired and the other time you're not tired. Your consistency is going to be affected. So yes, random errors are going to affect validity. They're also going to affect reliability. But what are systemic errors? Systemic errors are in the machine. Will systemic errors affect validity? Will they affect accuracy? Systemic errors, error in the machine. Will they affect accuracy? Yes, they will affect accuracy, right? Because there's an error in the machine. But if there is an error in the machine, will it affect the reliability or will it affect the consistency? Why not? Because your weighing scale is calibrated to 5 pounds. Every person that I'm measuring, every person has that 5 pounds error. Is it consistent? Is it a consistent error? It's a consistent error, right? It's a consistent error because everybody is going to have 5 pounds more. So it's consistent. So systemic errors affect validity, but do they affect reliability? No, they don't, because they don't affect the consistency. Okay, random errors can affect both validity and reliability, but systemic errors only affect validity. They don't affect reliability, because what is reliability? Reliability is all about consistency. And if you have a systemic error, will you have consistent errors also? Where are your answers? Will you have consistent errors? If you have your errors will be consistent, right? If you are having it will be, everybody is going to weigh 5 pounds more. So is it affecting reliability in any way? It's not affecting reliability. So going to repeat again, a random error can affect both reliability and validity. But a systemic error, which is in the machine, is going to affect validity for sure, because it affects the accuracy, but it does not affect reliability. Clear? Awesome. Great. So 2 more topics done, reliability and validity. How do you feel about research so far? Yes, systemic errors are always due to an instrument error. They're always going to be consistent. Let's take a break from this and let's do a couple of practice questions, okay? Like from Therapy Ed, I have some practice questions from Therapy Ed. I'm going to send them. Let's just do that. Systemic errors will affect only validity. That is correct, Beatrice. Okay. Okay, there are these 2 questions from Therapy Ed. Let's do them. Okay, I sent the question. Let's start with a group of 10 patients. Okay, a group of 10 patients is recruited into a study. Let's do that one. Okay, I'm still getting answers. Okay. A group of 10 patients is recruited into a study investigating the effects of relaxation training on blood pressure. One is participating in a supervised cardiac rehab, including relaxation. The other one is instructed to just do whatever they're doing without any proper instructions. Conclusion, there was no significant difference in the blood pressure. Now, what is the description? Rehabilitation group was not properly monitored. Do you think that was the case? Which is the rehabilitation group? Okay, if you're looking at If you're looking at, don't change your answers, you're going to regret it. If you're looking at 1, rehabilitation group was not monitored. Which is the rehabilitation group? Look at this. A group of patients scheduled to participate in a cardiac rehab program that includes relaxation training 3 times a week. Okay, so this group was actually supervised. Okay, this group was supervised. The other group was not supervised. So 1 is wrong, because the rehab group was not properly monitored is not the correct answer. The rehab group was monitored. You are giving them a supervised cardiac rehab program with relaxation training 3 times a week. They're telling you that the rehab group is properly monitored. They have mentioned that in the question. So if you answered 1, you change your answer to 1, you're going to regret it. Option 2, both the groups had been BP initially too high so that the reductions so high that the reductions should have been expected. Do you think both the groups had high BP initially? Did they ever mention anything like that? No. The activities of the non-rehab group were not properly monitored. So the other group, they say that the group is instructed to perform activities as usual. Did they tell them what they have to do? Did they tell them you are supposed to do relaxation training? Did they tell them? Nothing. Maybe those people in the other group worked out more. They must have thought, let's get good result, and they worked out more than usual. Right? So that group was not monitored at all. So that could have given you such results. And cardiac rehab is not effective in reducing BP. How can you say that when you've not done your examination properly, when you cannot conclude something is not effective if you've not conducted the study properly. So 4, definitely not the answer. 1 is not the answer because they've mentioned in the question that the rehab group was supervised, and both groups had initially high is not mentioned in the question. So option number 3 is answered. Okay, they were included in the study. They must have been monitored. How do you know that, Rashmi? They have mentioned that the other group was asked to perform activities as usual. So they're the control group. Do whatever you want. So the control groups are like, they are not really, maybe they're at home, they're doing whatever they want. So they are not really proper instructions were not given to the non-rehab group. Okay, and questions, yeah, how do you know that the BP is reduced significantly? I mean, the BP is reduced significantly, that's correct, right? But that doesn't mean that it's accurate, right? Because maybe the group was not monitored, which is why the BP would have reduced significantly, correct? So 4 is not correct because you did not do the study properly. You should have given the control group a strict instruction that don't do anything, or you should have told them, okay, that you are only allowed to do so and so. But they were not even monitored. They were not told anything. They just said, do what you do every day. So that's the problem here. Got it? To the next one. Wow, you guys are fast. Okay. A researcher uses a group of volunteers to study the effects of therapy ball exercises, range of motion, and balance scores. 20 volunteers participated in the 20-minute ball exercise class 3 times a week for 6 weeks. Measurements were taken beginning and the end. Significant differences were found in both the scores and reported that at the physical therapy meeting. What is the most accurate in what is the most accurate information? The reliability of the study was threatened with the introduction of systemic error of measurement. Was there any systemic error here? Have they mentioned anything about systemic error? And another thing, based on what I told you about random errors and systemic errors, do you remember? Is systemic error a problem for reliability anytime? Do systemic errors affect reliability? No. So your option 1 is actually completely wrong. Option 2, Hawthorne effect may have influenced the outcome of the study. Does it say anywhere that the students were observed? I mean, the volunteers were observed. So it's nothing to do with the Hawthorne effect. Validity of the study was threatened with the introduction of sampling bias. Can I say that? How? Because you just used a group of volunteers. You used healthy students. And what did you use it for? You to study the effects of therapy ball on ankle range of motion and balance. So you just used volunteers. You did not use any study population. So you did do a sampling bias. You just did convenience sampling. Whatever you got, you picked them up. Correct. And therapy ball exercises are effective intervention to improve ankle stability in chronic ankle sprain. Now tell me here, is there were the subjects who had chronic ankle sprain? Then how is it an effective intervention in improving chronic ankle sprain? It's not. So your answer is going to be 3. Clear? Great. So there comes an end to your reliability, validity kind of questions. Okay, good. Next topic. Let's move on. Next topic is about sensitivity specificity. Okay, little tricky. Again, tell yourself you love sensitivity specificity. You're going to love it. Okay, awesome. Yay. All right. Now, what is sensitivity? Okay, sensitivity is the true positive rate. Okay, it's a true positive rate. Why is it true positive rate? It helps us in identifying it's basically the test's ability to identify the proportion of individuals having the disease. Okay, so from the population, it helps us to identify the proportion of individuals who actually have the disease. That's why it helps us in identifying the true positive. So sensitivity is a true positive rate, helps us in identifying the true positive rate. What is the formula of sensitivity? Okay, I'm going to make you do different things. So don't right now confuse with spin and snout. We will come to that. Okay, just giving you a heads up. We will come to that. Just understand this first. Okay, so sensitivity is your true positive rate. Okay, it helps us in identifying the amount of people who actually have the disease. Okay, so it's true positive divided by true positive plus false negative. So this is your formula for your sensitivity. How do you remember? Just replace true positive with the opposite of it. So instead of T, put F. Instead of P, put N. So true positive divided by true positive plus false negative. Okay. Sensitivity helps us basically eliminate the false negatives. Okay. So that is why it's your true positive rate. Okay. So that's your sensitivity. What is the specificity? Specificity is your true negative rate. It helps us to identify the proportion of individuals who do not have the condition. Okay, so that means specificity is equal to true negative divided by true negative plus false positive. Okay, so sensitivity helps us to identify the proportion of the people having the condition, and specificity the proportion of the people who do not have the condition. Okay, yes, they do ask this formula in the exam. Pretty important, and just not the formula. They can also help you. They can also ask you to calculate from a question. Now question, I'm coming up with a question. Okay, first I want you all to be able to identify what is true positive, what is true negative, what is false positive, what is false negative, because that is important. Now, what do we understand by the term false positive? Okay. How I remember it? I remember it as I always take whatever this positive is here, I take that as a test. So it's going to be like, if I say positive, that means test is positive. Okay, false positive, but false, but patient does not have the condition. I always look at what is the sign, positive or negative, and I replace it with a test. So if it's false positive, That means test is positive, but the patient does not have the condition. Again, false negative. What do I mean by false negative? What is happening to the test? What do I mean by false negative? What is happening to the test? Test is negative, but the patient has the condition. Okay, so I always look at the test and then I have to just reverse it. Okay, so the test is negative, but the patient has the condition. Okay, let's review it. True positive is basically your test is positive, patient has the condition. True negative is the test is negative, patient does not have the condition. Okay, so patient is testing negative for a negative condition, that's true negative. Patient is testing positive when he actually has the condition, it's true positive. But if the patient tests positive and does not have the condition, that's going to be your false positive. Like your male, let's say a male being positive on a pregnancy test. What is happening? Test is positive, but can males be pregnant? So example of false positive is a male being pregnant. Okay, so test is positive, but the patient does not have the condition. And false negative is test is negative, but the patient has the condition. Maybe pregnancy test showed for a female, it showed negative, but I may be pregnant, right? So that way, so test shows negative, but you may be pregnant. All right, so that's a false negative one. Okay, so false positive, false negative. Good. Everyone understood what is true positive, what is true negative, what is false positive, what is false negative. And sensitivity is your true positive rate. It helps you identify the true positives. And specificity is your true negative rate. It helps you identify the true negative. True negative is you test negative when you don't have the condition. True positive is you test positive when you actually have the condition. False positive, you test positive when you actually do not have the condition. False negative is you test negative when you actually have the condition. Good? All right. Now, let me give you a scenario. Okay. There are 100 patients. Okay. 100 patients diagnosed with bicipital tendinitis. Okay. 60 people, okay, 60 people, 60 patients had speech test positive. Remaining had speech test negative. Tell me what is 60 here? Is it the true positive? Is it 60 is my true positive. If I have to calculate the sensitivity here, okay, what is the false negative here? What is my false negative here? What is the false negative? False negative is 40. Excellent. So if I have to calculate the sensitivity, 60 divided by 60 plus 40, how much is my sensitivity? 60% or 0.6, right? So that's my sensitivity. Can I calculate specificity from this same question? I mean, same thing? No, I cannot. I need a different question. My question should say 60 patients are who are not diagnosed with bicipital tendon. 100 patients who are not diagnosed. 60 patients had speech test positive and remaining had speech test negative. So now, what can I calculate? I can calculate my specificity. So what is my true negative? 40. What is my false positive? 60. Excellent. So what is my specificity? 40%. Awesome. Great. Okay, let's do a question on this. What I want you all to do here, okay, I just want you all to use a calculator because such a difficult question, such a difficult calculation will not come in your exam. Okay, in your exams, they'll give you a little easier calculation. But I want you all to do this question just so that you understand the question, so that I'm satisfied that you've understood it. I should say it's for myself. Let's do this. This is from your Final Frontier exam. Okay. Use your calculators here. That's fine. I just want you to be able to tell me how to differentiate the true positive, true negative, false positive, false negative. I'm going to give you 2 minutes to do this question and then we'll move on. Use your calculators. Okay, in this question, first let's break it down and tell me what is, okay, out of the 125 patient who had TOS, 25 tested positive and the remaining tested negative. What is the true positive here? How much is the true positive? 25. And what is the 100 here? Remaining tested negative. What is the 100 there? False negative. Excellent. Okay, so your sensitivity is going to be 25 divided by your 125, right? And out of the 40 patients who did not have TOS, 9 tested positive and the rest tested negative. So what is 9 here? False positive. And what is the true negative here? How much is it? 31. Good job. Now just use the formula for sensitivity, specificity, and I think A should be your answer, or D. Which one is the answer? I don't know. I did not calculate, but you already all get the answer. A? Perfect. So A is going to be your answer. If you've not done it, you could do it later, but you won't get a tricky calculation in the exam. You get a pretty simple calculation in the exam. How did you get D? Okay, very complicated. Okay, so how do you calculate sensitivity? Sensitivity is going to be 25 divided by 125. So either you are switching the formula for sensitivity and specificity, that is why you got the answer as D. Okay, so sensitivity is 25 divided by 125 and specificity is true negatives. I think 31 divided by 40, right? 31 divided by 40, that's your specificity. So if you have swapped the formula for sensitivity specificity, then you got your answer as D. So be careful with that. They will not give you this difficult calculation in the exam. Don't worry about it. Okay. Okay, so this was one part of sensitivity specificity, where I just wanted you all to understand that sensitivity is a true positive rate, specificity is a false your true negative rate. Okay, true positive rate, true negative rate. It helps you identify true positives. It helps you identify true negatives. Okay, the other type of question that you can have is about your S spin and your snout, spin and snout. Now that's a different concept. Okay, now what is that concept? That concept says that snout, Okay, now you know that sensitivity is very good with true positives, right? That means it's helping you identify all the people who have the condition, and it's very good at ruling out the false negatives. So when you have to remember this. When you have a high sensitivity, okay, the NSN, when you have a high sensitivity, this N stands for what? What is this N stands for? This N stands for negative test. So if you have a very high sensitivity, but your test is negative, what does that indicate? If you have a very high sensitivity and your test is negative, it indicates that you can rule out the condition. Okay. What is about a spin? Spin is if you have a very high sensitivity and your test is, if you have a very high specificity and your test is positive, what can you do? You can rule in the condition. Remember, this has to go hand in hand. If your sensitivity is high and the test is negative, you can rule out the condition. If your specificity is high and the test is positive, then you can rule in the condition. Can you say sensitivity high but test positive, I will rule out the condition? Does that make sense? No, you can never swap those. It only makes sense if sensitivity is high and the test is negative, you will rule out the condition. If specificity is high and the test is positive, only then you can rule in the condition. If they give you mixed things, does not make sense. You cannot rule in, you cannot rule out, it is non-conclusive. Okay, you can never rule in, rule out with other combinations. Beatrice, don't be sad. Listen to my lecture again. I'm going to repeat it again. Snout is a mnemonic that we use. So if they tell you that the sensitivity is high, high means, okay, the sensitivity is 90%, 0.92, 0.93, 0.98. That means it's a high sensitivity. Along with having a high sensitivity, if they tell you that the test is negative, okay, that's your mnemonic, snout, you will rule out the condition. That's the mnemonic. Okay, and your other mnemonic is spin. Okay, spin is if your specificity is high, and that means if your specificity is 0.9, 0.2, 0.98, and your test is positive, the P stands for positive, then you can rule in the condition. Okay, I will give you a question on this concept so we know that you are understanding this concept. Okay, let me send it to you. Okay, don't disregard the answer that is marked because the answer could be wrong. That's good, Philip. Exactly. So if you have a high sensitivity of a special test and the test is negative, you can rule out that condition, that the patient does not have that condition. Similar is our question here. Our question here is a PT is using a new special screening test to determine if the soccer player has ACL tear, high sensitivity, but the test is negative. So if you have a high sensitivity and the test is negative, you will rule out the condition. Yes, rule out means the condition is not present. Rule in means the condition is present. Okay, that's correct. It does not matter, Anushka, then it's not conclusive. Okay, that does not make sense. It only comes with spin and snout. Okay, it does not make sense. Okay. Now, this is a question that is not based on a spin and snout. It's just based on what is sensitivity, what is specificity. Now, based on that, what would you answer? I sent you one more question. Based on that, what would you answer? This is not based on a spin and snout. Not all questions are going to be based on spin and snout. Okay, remember that. Not all questions are going to be based on spin and snout. Think about our definition here. Sensitivity is a true positive rate. Specificity is a true negative rate. Based on that, solve that question. And don't look at the answer mark, that could be wrong. What is the sensitivity? It is how much percent? 32%. And what is the specificity? It is 98%. Sensitivity is a true positive rate. Specificity is a true negative rate. So what does option A say? There is a high possibility that a patient with ACL tear will test positive on pivot shift test. This is a true positive. Now, true positive, that is the sensitivity is only 32%. So can it be A? Can the answer be A because it's only 32%? No, but specificity is 98%. So there is a high possibility that a patient without ACL tear will test negative on the pivot shift test. So B is going to be correct here. Okay. Okay. Now, let's say, have you heard about what is positive predictive value and what is negative predictive value? Okay, what is positive predictive value? Now, sensitivity, you know, it was a true positive rate, specificity was a true negative rate. What is a positive predictive value? How do you calculate it? It's the true positive divided by your whole population. Yes, that means your true positive divided by your true positive plus your false positives. Okay, true positive plus your false positive, and negative predictive value is your true negative divided by your true negative plus your false negative. Correct? Okay. Now, what is this? The predictive values are your test's ability to predict who will test positive or negative for a condition. Now, sensitivity is not predicting. Sensitivity knows it that, okay, these are the people. Like if I'm negative, that means they don't have the condition. They have the condition, ruling in, ruling out. That's sensitivity. But if you're predicting, the test's ability to predict a percentage of the population. Okay, so prediction, if the word is, if they give you a word that says predicting, the probability that, okay, basically they will say, what is the probability that the test is there? Or, I mean, they are going to test positive if they have the condition, or probability that they are going to test negative when they don't have the condition. So keywords like probability, keywords like likelihood of the disease being present, or likelihood of the disease not being present, that's going to be called as your predictive value. That's when you're going to use predictive value. I'm going to send you a question to just for you to identify when to use positive predictive value, when to use negative predictive value, because usually you would tend to get confused between sensitivity and specificity and PPV and NPV. But if you have keywords like the probability or a likelihood, then you would pick PPV or NPV. So read the question that's given in your WhatsApp group and tell me what is the answer to that one. Perfect. It says that the properties on special test, that the likelihood of the disease present when the patient's test is positive. So Dolly, because it's not really telling you, there is a keyword like likelihood. It does not clearly telling you that there is a high possibility or something. They just say that, okay, it's likelihood, or it is, when they use the word likelihood, or when they use the word probability that the patient may have the disease if the result is positive, that's when you use like a word which is predictive value. Again, on the NPTE, predictive value is not going to be asked. I have not seen any time like students coming and telling that positive and negative predictive value was asked on the exam. They typically stick to sensitivity specificity. But just for you to know, yes, because it's assumption. So likelihood is a keyword here. Okay, so whenever they say likelihood, that time it's going to be more of positive predictive and negative predictive value. Okay. All right, perfect. Everyone clear? So we're done with one more topic, spin and snout and sensitivity and specificity. So if you see, okay, if you see, we finished so much. We finished independent variable, we finished the types of variables, we finished validity, reliability, sensitivity, specificity, and I think you guys are going okay, right? You're still going strong. Understanding everything? All right. Great. Okay. You still are going to have time. It is a little difficult because if you're not used to research at all, it's going to be difficult. But if you listen to it again, it's going to drill inside your head. Okay. You have to listen to it again, which is why I'm not keeping a class tomorrow. So you have time to review your research basics before we go to the advanced research. Okay. All right. Now we come to your research questions would be 4 to 5 in an exam. If you're, sometimes they are two questions, sometimes there'll be 5 questions. It kind of varies. It always varies every exam. Sometimes there are like 1 or 2 questions, and 2-3 questions are so basic, like they'll ask you dependent variable, things like that. So 2 or 3 questions are very manageable. 1 is always out of the box. Okay, no matter how much we try, we have to struggle. So I'm going to make sure that you are all at least get 4 on 5 or 5 on 5 on research if you review the lecture again, and if you remember, and if you make sure that everything that we speak is registered. Okay, let's talk about this curve. Okay, this is your normal distribution. What is this? This is called as your bell-shaped curve. Before doing this, before doing the bell-shaped curve, your measures of central tendency. Do you all know what is mean, median, mode? What is mean? What is mean? Mean is the average number of scores divided by your number of subjects. Okay, so if you have like you sum up all the scores divided by the number of the subjects, and that's going to be your mean. Okay, now mean is mean a ratio, interval, nominal, ordinal? What is mean? Mean is a strong data. So what is mean? Mean is usually mean ratio, interval. Mean is strong. It's going to be your ratio or your interval. Okay, so mean can be either ratio or it can be interval. What is median? Median is going to be the midpoint, right? Median is your midpoint. So wherever median is, 50% of the data is above the median, 50% of the data lies beneath the median. So that's like your midpoint, that's your median. And what is mode? Mode is the number, the one that is getting repeated the most. That's your mode. So what is median? Median is going to be an ordinal. Okay, they ask you what level of data is median. Median is going to be an ordinal. And what is mode? Mode is the most frequently repeating number. So mode is going to be your nominal. Okay, so median is a number. It's going to be ordinal. Mode is your nominal. And mean is a strong one. It can be interval or it can be ratio. Okay, now measures, those are your measures of central tendency. When you have a bell-shaped curve, that means everything is distributed symmetrically. Okay, in a bell-shaped curve, what is this midpoint? What is this midpoint in a bell-shaped curve? I don't think so, Divya. Okay, come on, bring your answers. What is this midpoint in a bell-shaped curve? This is mean, median, mode. Always in a bell-shaped curve, that means your Data is normally distributed, symmetrically distributed, normally distributed. So when your data is normally distributed, okay, that's a bell-shaped curve. And your mean, median, and mode is always at 1 point, okay? That's your mean, median, mode. Then after mean, median, mode, you have something which is called a standard deviation. All of you all have heard what is standard deviation? You don't need to calculate in the exam, so don't worry. You have a standard deviation in your exam. It's your, once you calculate the variance, your square root of your variance is your standard deviation. You don't need to know how to calculate it. They will not ask in your exam. But why do I tell you standard deviation? Because from the mean, you have 1, 2, 3. What is 1? Plus 1 standard deviation. What is 2? Plus 2 standard deviation. And this is plus 3 standard deviation. Okay. Now that's your right side of the curve. Right side of the curve is positive. Left side of the curve is negative. So you have -1 standard deviation. You have -2 standard deviation. And you have -3 standard deviation. Yes, when it is a normally distributed curve, which is a bell-shaped curve, the mean, median, mode will always be at the same point. Okay, so +1, +2, +3 standard deviation, -1, -2, -3 standard deviation. So there could be a question, what is the percentage of the people lying within 1 standard deviation of the curve? So within 1 means -1 to +1, that is within 1 standard deviation from -1 to +1. What is the percentage of the people lying there? 68%. You have to memorize this. There is no other way of remembering the value. You have to memorize it. What is the percentage of the people lying within 2 standard deviation? It's 95%. And what is the percentage of the people lying within 3 standard deviation? That's going to be 99%. So you have 68%, 95%, and 99. This is within 1 standard deviation, within 2 standard deviation, within 3 standard deviation. If my question says, what is the percentage of the people lying 1 standard deviation above the curve? Let's say 1 standard deviation above the mean. They just say lying 1 standard deviation above the mean. Above the mean means it's going only to the right. When I say below the mean, that means it's going only to the left. So if I say percentage of the people lying 1 standard deviation above the mean, it's going to be 34. What if I say 1 standard deviation of the people lying below the mean? Still 34. Percentage is never negative, guys. Math, percentage is never negative. It's still 34. Percentage of the people lying 2 standard deviation above the mean. 2 standard deviation above the mean. Percentage of the people lying 2 standard deviation above the mean. 68 divided by 2. So that's somewhere between your 47.5. Okay, same thing, 2 standard deviation below the mean, 47.5. 3 standard deviation above the mean. 99 divided by, I think it's going to be 49.5. So you have to read the question very carefully. Are they asking you within 1 standard deviation, within 2 standard deviation, within 3 standard deviation, or 1 standard deviation above the mean, below the mean, 2 standard deviation above the mean, or 2 standard deviation below the mean, or 3 standard deviation above the mean, or 3 standard deviation below the mean? If they ask within, you don't divide by 2. But if they ask above or below, you divide by 2. Clear, everyone? This is your bell-shaped curve. Usually when we do parametric tests, we do parametric tests when when the data is all homogeneous and when they have this normal distribution and a bell-shaped curve. But not every time you're going to have a bell-shaped curve. When your level of data is low, let's say you're using a lot of nominal data, you're using a lot of ordinal data, you may not get a good bell-shaped curve. You may not get this good normal distribution. What will the distribution be then? This is a normal distribution. What will the distribution be? If it's not normal, it will be skewed. Skewed means the skewness can be like this, okay? Or the skewness can be like this, okay? In this image, in figure A, where is my tail? Is my tail to the right or is my tail to the left? My tail, this is the tail, okay? This is the tail. My tail is to the right. So I will name the side of the skewness based on the tail. This is a right side skewness or a positive skewness. So this is going to be a right side skewness or a positive skewness. Okay. Now this one, this B, what is this? This is going to be a left-sided skewed curve or a negatively skewed curve. This is a right side skewed curve or a positively skewed curve. This is a left side skewed curve or a negatively skewed curve. Okay. So if the tail is to the right, okay, where do you think is more population? Is the more population towards the left or to the right? Great. So you see right here, more population. You see that there is so much population here. So more population is towards the left and the tail is towards the right. So is more population above the mean or below the mean? Below. Why below? Because it is left, right? Now in this curve, that is figure B, it's a left-sided skewness or a negative curve. Where is the population more? On the right side. Okay, so is more population above the mean or below the mean? More population is going to be above the mean. Cleared what is skewness, what is normally distributed curve. So that was your normal distribution of the curve, which was a bell-shaped curve, +1, +2, +3 standard deviation, -1, -2, -3 standard deviation. The next one was your skewed deviation, skewed curve, okay? It's not a normal distribution, it's a skewed. It can be a positively or a right-sided skewness. It can be negative or a left-sided skewness. A right-sided skewed curve is positive with more population to the left below the mean. A left-sided skewness is negative with more population to the right above the mean. Is this clear? Okay, good question, Pasha. Good question. Okay, now always remember that the mean is getting pulled towards the tail. Okay, Vasundhara, definition of mode is the number that is repeated more frequently. So if you have a data that is scored as 12, 13, 13, 13, 14, 12, 13, 13, 13. So 13 is the mode because the number that is getting repeated most frequently, that's called as a mode. And we consider it as a nominal level of data. Okay, now always remember the mean is getting pulled towards the tail. So if I have, like usually in a bell-shaped curve, you know my mean median mode is at one point, right? If my mean is getting pulled towards the tail, so here is my mean, what will be in the middle? Median. And what will be towards the end? It will be mode. So it's very simple to remember this because you know median always comes in the midpoint and the one that gets pulled towards the tail is always going to be the mean. Same thing here, your mean is going to be here because it's getting pulled towards the tail. The one in the midpoint is going to be median and then it's going to be mode. Here the mean median mode will not be at the same point because it's a skewed distribution. All right, now test time to see if you guys have really understood this or no. Let's give you some questions. One simple question. And let's do this. And one tough question, and then I will make you do another question. Mean is getting pulled to the tail, Anushka. Okay, to why? Because it says, what does it say? What is the keyword? Between the mean and one standard deviation above the mean. So they're asking you the population that is between the mean and one standard deviation above the mean. So that's going to be 68 divided by 2. That's going to be 34%. This was a very simple question. Now is the tricky question. Do the next question, which says, question number 146, which says the National Survey helped. Okay, do that question. It is a tricky question. Don't worry. But we will have a trick to solve this. When you get questions like that, okay, when you get questions like that, always look at the mean. What is the mean in this question? The mean in this question is 65, okay? The mean in this question is 65. What is the standard deviation? 2.5, okay? Now, if I say plus 1 standard deviation, okay, what are you going to do with plus 1 standard deviation? You will just add the mean and the standard deviation. So when I say plus 1 standard deviation, what is it going to be? It's going to be 65 plus 2.5. So that will become 67.5. What is plus 2 standard deviation? You will do 65 plus 2.5 plus 2.5 because 2 times. So what is plus 2 standard deviation? It's going to be 70. Okay, because you're going to do 65. It's 2, right? 2 standard deviation. So 65 plus 2.5 plus 2.5. Okay, everyone getting me? Plus 1 standard deviation was just 65 plus 2.5 because it was plus 1 standard deviation. Now you have plus 2 standard deviation. So 65 plus 2.5 plus 2.5. What is plus 3 standard deviation? 65 plus 2.5 plus 2.5 plus 2.5. So that will become 72.5. Okay, that will become 72.5. Now, how much would be minus 1 standard deviation? Minus 1 standard deviation would be 65 minus 2.5. That would be 62.5. What would be the minus 2 standard deviation? 65 minus 2.5 minus 2.5, that would become 60. Okay, and what would be minus 3 standard deviation? Minus 3 standard deviation would be 57.5. Okay, good job. Now, all you got to do is, instead of this plus 1, plus 2, plus 3 in this table, all you got to replace plus 1 by 67.5, plus 2 by 70, plus 3 by 72.5. Instead of minus 1, you will put 62.5. Instead of minus 2, you will put 60. And instead of minus 3, you will put 57.5. Now, what have they asked in the question? They have told you what percentage is between 62.5. That means what is 62.5? 62.5 is minus 1 standard deviation. 2, they are telling you 67.5. So they are asking you the percentage of people from minus 1 to plus 1 standard deviation. What is that? Minus 1 to plus 1 standard deviation, that is 68%. If they asked you, what is the percentage of the people lying between 70 inches to 60 inches? What your answer would have been? 95. Great. Or if they ask you percentage of the people lying between 65 and 67.5. 65 and 67.5. Don't randomly assume that I asked you 3 standard deviations. 65 and 67.5, that is 34. Or if I tell you between 65 and 70, that would be between 65 and 70 would be 47.5. Perfect. Understood the question? Great. Good job. Perfect. One more thing that I want to tell you. Okay, if you get a question that says that a patient has adhesive capsulitis, okay, a patient has adhesive capsulitis. I mean, a patient is reading an article on adhesive capsulitis. In the graph form, okay, in the graph form, it shows 70% of the people, okay, this is 70% of the people falling below the established mean value. Okay, a student is reading an article on shoulder mobility, and in the article she identifies there's a graph which shows 70% of the subjects are falling below the established mean value. Okay, which of the following is the most accurate representation of the graph? A, negatively skewed curve. Okay, negatively skewed curve. B, normal distributed curve. C, right-sided skewness. And D, it's a sampling error. Come on. Be very thoughtful. Draw the graph. Don't be in a hurry. Don't be in a hurry. It says 70% of the people are falling below the mean value. If 70 are falling below the mean value, that means where 70% means the population is on the left. If the population is on the left, where is the tail? So what side skewness is what side skewness is the curve? Right-sided skewed curve, which is why important to read the question well, because you know the concept, you just have to apply it. Pasha, no need to be quick. You have enough time. Just apply your concept. You're fine. Don't be quick. All right, everyone good with this? Yes, you should take your time. Okay, I'm going to share another picture that can help you guys. Okay. I shared a picture of a normal distributed curve, of a skewed curve, okay, of a right-sided skewness, of a left-sided skewness, so you don't forget that. Okay, good. Okay, this has felt like a long class. I know it's been only 2 hours. We'll only do 30 minutes more. 7:30 we'll be done. We won't exceed even 1 more minute than 7:30. It's too difficult to take research more than 7:30. I can completely get that. Okay, so don't worry. Okay, research is too much to go on for 3 hours. That's why I divide my research classes into 2. So don't worry about that. Okay. Great. Now, why was C the answer? Because Divya, 70% of the people were falling below the curve, below the mean value. So if you're below the mean, means you're on the left side. So there is more population on the left side. The tail is towards the right side. If the tail is towards the right side, it is called as a right-sided skewness or a positively skewed curve. Okay. All right. Now the next thing is I want to talk something light. Let's talk about the type of studies, type of research designs that we have, because this is now building up a base into your next class. Next class is going to be a little more, next class is going to be a little more, let's say, intense, but it's going to be interesting. Okay, so don't worry. All right, now our first thing is going to be our types of study design. Okay, so type of study design. Let's start with your simple. Which one do you think is the most common one? What do we keep hearing about all the time? RCTs, perfect. Before that, let's discuss what is qualitative and what is quantitative study. Qualitative studies are studies that are not numerical. Okay, qualitative studies that are not numerical. They have like a small sample size. Okay, so they are studies that are just like just about people's experiences, doing surveys, just as a hypothesis, just simple stuff. Like you're not really doing a numerical study, you're not doing any you're not doing any statistics, nothing. Qualitative studies are just you use small sample size, you conduct survey, you take people's opinions, you have a hypothesis. Based on people's opinions and investigations, you make your thing. That's a qualitative research. Quantitative research is something that is numerical. It should have a bigger sample size. It should be done in a way where you are able to do a statistical study, and after that you are able to apply the results to the entire population. Okay, that's what a quantitative study is. Now, qualitative study is your qualitative studies are not really accurate. Quantitative studies are what are going to be accurate. Now, when we talk about the types, okay, you have your RCT, very, very important. Your RCT is a very strong study design which has two groups, which has a experimental group and a control group. Always remember two things about RCTs, okay? RCTs always have an experimental group and RCTs will have a control group. What do we mean by control group? Control group is where nothing is done. You don't really do anything to the patient. They're taken as a control. An experimental group is a group which is where you are actually conducting the experiment. Okay, experimental group is where you are conducting the experiment, and control group is where you are just not like it's just your baseline. Okay, now with an RCT, always there are going to be two groups, experimental and control. Remember, RCTs always have a control group. Second thing which is very important in RCT is randomized. So your sample is randomized. You will do random sampling, so you have everyone from the population. So remember two things with RCT, you will always have an experimental group and a control group and a randomized. So let's say you want to see the effect of TENS on improving the range of motion. So you will give TENS to the experimental group, you will not give TENS to the control group, and the patient population that you have chosen is going to be random. Right? Understood what is an RCT? Okay. Now you also should know what is a true experimental design. Okay. What is a true experimental design? True experimental designs are always the designs that have a cause and effect. Don't ever forget that. So true experimental designs always have a cause and effect, means this will happen because of this. To improve the range of motion. Range of motion improvement is seen with TENS. Range of motion improvement is seen with ultrasound, right? Or pain improvement is seen with something. So you always have a cause and effect. Okay, for a true experimental design, you will always have a cause and effect. So your RCT is an example of true experimental design. RCT is also called as a between subject design. Okay, let me put it here. Why did I call it a between subject design? Why did I call it between subject? Because there are two groups. You are comparing two completely independent groups. What are two completely independent groups? If there are 30 people, I have randomly chosen 30 people. Randomly 30 have been put into a experimental group, and out of 30 people, randomly 15 have been put into an experimental group, 15 have been put into a control group. What are these two groups? Are these groups independent or are these groups dependent? Tell me. If there are 30 people, I have put them in one group into 15, other into 15. One is given tense, one is given nothing. Are these two groups independent or dependent? These groups are called as independent groups. Why? Why are they called as independent group? Because they are completely two separate groups, group A, group B, with different people in both groups. Group A has 15 different people, group B has 15 different people. Group A is given tens, group B is given nothing. So that is why RCT is a true experimental design, because RCT always is a cause and effect. Okay, with RCTs, we always have a control group. We have randomization. It's also called as a between subject design. Got it? Everyone understood why independent group, why between subject design? Now why did I do this? Why did I tell you about between subject design? Because I want you all to know what are dependent groups and where do you see dependent groups. Dependent groups are going to be seen in a within subject design, okay, or a repeated measures design. Within subject design or a repeated measures design, again, a true experimental design, okay, it's a true experimental, will have cause and effect. What is the difference between a between subject design and a within subject design? What is the difference? Within subject design mean there are 30 people in the group. Remember, in the between subject, we divided them into 15, 15, group A, group B. Now this 30 people are group A, they have been given tens, okay? We are checking the range of motion like in group A with tens. Same 30 people are also given ultrasound. Okay. Same 30 people will also be given some other modality and you have to compare which one of them have better results. Is it different people in different groups or is the same people in group A, group B, group C? When you have a same group of people that are being given multiple interventions, or you have a same group of people where you're checking the before and after. Before is group A, after is group B. Like before getting tens, their values are this. After getting tens, the values are this. Like before, after, and then again after giving ultrasound, the values are this. And after giving, let's say, before giving ultrasound, values are this. After giving ultrasound, the values are this. You are testing in the same group of people. They become dependent group. Okay, so earlier you have 30 students, group A, group B. So they were like 15, 15. Okay, group A was given something else, group B was given something else. They are completely independent group. This is called as a between subject design. The other one is a within subject design or called as a repeated measures design, where the same 30 people are going to get different treatment and they are going to be same 30 people in group A, same 30 people in group B. Makes sense? Why is it called as a within subject design? So here you don't have a control group. The subjects act as their own control because they know what they were before and what they are after, right? Before giving tens, after same group of people you're testing. You're not having a other separate group which is called as a control group. The same people are acting as their own control. That is called as a within subject design or a repeated subject design. And these groups are called as dependent groups. Why am I teaching you dependent groups? Because it's going to create a base for you when we do parametric, non-parametric, which test to use. This is creating a base for that. Okay. So everyone understood what is a between subject design? What is a within subject design? Great. Okay. So within subject design and between subject design, can I say both of these are cause and effect? To see the effect of tens, to see the effect of ultrasound, to anything, like both of these are cause and effect design? Yes. Which is why your RCT and your within subject design or a repeated measures design, they are called as your true experimental designs. Okay. Why they are dependent groups till we see results? I didn't understand. So Betul, if you, it's the same group. Let's say I want to see whether TENS is doing better on you or whether ultrasound is doing better on you. So I am going to be giving you TENS. I'm going to see the difference that you have in range of motion with TENS. Then I'm going to give you ultrasound and I'm going to see what is the difference with you with ultrasound. Eventually, I want to compare, right, whether TENS is doing better or ultrasound is doing better. So I want to see who is having a better range of motion. That is why you are acting as your own control, but I still have to have my result, which is better, whether TENS is better or whether ultrasound is better. So you are comparing it with yourself, but yeah, you are comparing the results. It is important. How will you know whether you got better or you didn't get better? Right? What is the reason for comparing? To identify if something is actually causing an improvement or no. Okay, if like in RCT, like whatever, let's say you have a control group and you have an experimental group, you see that TENS is showing improvement only with the experimental group. That tells you that, okay, TENS is good, TENS is better, right? RCT can have within subject design too. Okay, so usually we don't consider RCT as a within subject design. RCT is for NPT, always remember RCT is going to have an experimental group. RCT is going to have a control group. There's going to be randomization, and it is a between subject design. Within subject design is another type of true experimental design, where you are acting as the same group of people. You're using dependent groups. RCT is independent groups. Okay. What is a type of a within subject design? I think you all have done this in your, you all might have read this in your therapy. Have you heard about your single subject designs like AB, ABA, ABAB, those type? Those are within subjects, right? Why are those within subject? What is A? What is design A? A is Devanshi, true experimental design means it is going to be a cause and effect. In your RCT, yes, you will divide them equally. In within subject, there you don't need to divide. It's the same group of people that are going to be in multiple groups. What is in your within subject design, repeated measures design? Have you heard of that single subject design AB type? What is the AB? What does AB mean? What does A mean? What does A mean in that AB type? Come on, you guys have done this. No, A is your baseline values. So before doing any intervention, when you put down their measurements, that is A. What is B? B is in the same group of people, after you give an intervention, let's say after you give TENS, what are the values? That is B. So A is same group before giving the intervention. B is same group after giving values of the same group after giving the intervention. Yes, you can say A is a pre-test and B is your post-test. That is your AB type of a design. Then you have a ABA type of a design. What is an ABA type of a design? Again, A is measurements in the group before treatment. B, measurements in the treatment, measurements in that group after treatment. Let's say you discontinue the treatment. After discontinuing the treatment, again, when you start measuring again, what will that be? A. So if you see the values before treatment, after treatment, and after stopping the treatment, that's a ABA. Okay. A is baseline. B is after giving the intervention the values. And the A again is, let's say you stop the intervention, you again come down, that will be your values, that is A. AB, the first type of design is AB, where A is your baseline, B is after the intervention. ABA is baseline, after intervention, again after stopping the intervention when you're almost near baseline again, that's your ABA. Next one you have AB, AB. What does AB, AB mean? A is again baseline, B is after giving the intervention. Let's say you stopped the intervention, is your A. What is this B? You started the intervention again. So AB, AB. Okay? Getting it? AB is before, after, ABA is before, after, and after stopping it. AB, AB is before, after stopping it, and then again when starting it. So AB, AB. Everyone clear with these designs? What is AB type of design? What is ABA type of design? What is ABAB type of design? Now you have AB, last one is ABC. What does ABC kind of a design mean? Okay, A means baseline, B means after giving the intervention, and what does C mean? What does C mean? A completely new intervention that you are giving. So that is your C. That's a second treatment that you are given. Okay, so A is your baseline, B is your treatment number 1, and C is your treatment number 2. So you ask me what is AB? A is baseline, B is after giving the intervention, A is when you come, like A is after stopping that, after stopping the intervention when you're again at baseline, almost baseline, that's A. And B is again after starting the same intervention. Okay, so you have AB, you have ABA, you have ABAB, and you have ABC. Now, do you think this kind of a study design can happen in independent groups, or will it happen only with dependent groups? What do you think? This kind of a design that we did, AB, ABA, ABAB, it has to happen in dependent groups because the same group of people are exposed to A before, after, right? Which is why this is a within subject design or a repeated measures design. Is that clear? So we did 2 types of true experimental designs. True experimental designs are the designs that only have that only have a cause and effect. Okay, only true experimental designs will have a cause and effect. Your RCT is a true experimental design, and your RCT is a true experimental design, and your within subject or a repeated measures is a true experimental design. Your other design, which is now coming on to the other studies, your cohort study. What is a cohort study? Cohort study means when you're studying a group of people over a period of time. Now, cohort studies may not have randomization, not necessary. Cohort studies may also not have a control group. It's not necessary. What is cohort? You have a cohort. Let's say I have a group of multiple sclerosis patients whom I am studying over a period of 1 year. That is a cohort study. You guys are my cohort. I am working with you for a period of 3 months to see your results. Yes, you are my cohort. That is a cohort country. Yeah, you are my cohort. Okay, so that is your cohort study. When you're studying a group of people over a period of time, that is a cohort study. Now, cohort may not have a control group. It may sometimes not even have randomization. It's not necessary. If I am taking a group of multiple sclerosis, cannot be randomized, right? I know my population that I'm going to study. I cannot randomly pick anyone. I know my population that I have to study. So that is going to be your cohort study. Clear? Okay. Now your case control. What is your case control study? Now remember, none of these, like your case control, case series, case reports, these are not going to be your cause and effect. Why? Because they are studies that are going backward in time. So your case control, case report, case series, do they go forward in time or do they go backward in time? Case control, case series, case report, they go back. What is case control? Case control means you have 2 groups. Okay, one is a control group and one is a experimental group. Okay, you are studying them backward in time. So let's say I study a group of people. Okay, I'm studying a group of people who have passed the NPTE. Okay, one group, that is the case group. The case one is who took NPT Final Frontier coaching, and the control one who did not take Final Frontier coaching, but both of them have passed. So I am studying both of them backward to see what they did. So that what are the factors that they did so that they passed the NPTE. So that's a case control. So you're studying a control group and a case group backward in time to see how they got those results. Okay, that's a case control. Okay, it's a retrospective study. What is a case series? Same thing, you're studying one group of person. Okay, case series, case report. Report is only studying one person. Okay, let's say Emily. Emily is a team member with us, and Emily scored 800 on 800 on the NPT. So if you are studying Emily, you are doing a whole in-depth study, you're making a report on her, Okay, one individual is studied in depth in case report. So I'm going to make an entire report on Emily that, okay, what all did Emily do to pass the NPT? So all my backward. So that's a case report. Okay, case series is when you study a group of people backward. Case report is when you study one person, in-depth study of one individual backward in time. So case control, case series, case reports, none of them are true experimental designs. They are all studied backward in time. It's no cause and effect relationship here. Okay, everyone clear? What is case control, case series, case report? Okay, what is an RCT? What is independent groups? What are dependent groups? What is a within subject design? What is a repeated measures design? Awesome. Okay. Now, a case series is when you study a group of like a cohort. Like, let's say if I'm studying one cohort in depth, backward study in depth of one group. Okay. Yes, you can do case series on clinical patients. You can do case report on one clinical patient. You can do it on anyone. Okay. So that's your case series. Now, correlational studies are just a relation. I'm not going to do your entire correlation right now, but I'm just going to tell you what is a correlation study. Correlation studies are when you are correlating a group, when you're correlating two variables. Is this a cause and effect? Are correlational studies cause and effect? No, they're never cause and effect. They're just a relationship of one variable to the other variable. One variable does not cause the other variable, and one variable is not the effect of other variable. It's just a relationship between the two variables. It can be positive, it can be negative. When we do correlation, I'll explain you positive correlation and negative correlation. Just wanted to tell you that correlational studies are also not cause and effect. Okay, so everyone clear? Now, the last thing we're going to talk about, which you already know, is a pyramid. Okay, is this pyramid of your highest evidence. What comes at the top of pyramid? Is a systemic review and your meta-analysis. Now, what is a systemic review? Systemic review is a compilation of all the studies, okay? Meta-analysis is a statistical correlation of all the studies. So systemic review is a compilation and meta-analysis is a statistical correlation of all the studies. So that is your system, that's going to be your systemic review or your meta-analysis that's going to come at the top, okay? So systemic review is a compilation and meta-analysis is statistical analysis of all. Okay, multiple studies. Now, the top pyramid is going to be systemic reviews of which studies? RCTs or case control or cohorts or case series. They are going to be systemic reviews of RCTs. Remember, if they tell you systemic reviews of case control, case series, that's not going to be the top of the pyramid. No, only systemic review and meta-analysis of RCTs is going to be the top of the pyramid. After this, what do we have? RCTs. After RCTs, what do we have? We have your cohort. Okay, we have your cohort. After cohort, what do we have? Case control. After case control, there is something also called as a cross-sectional. What is cross-sectional? Cross-sectional are just done as an observing to identify the observance. Okay, cross-sectional are done just is basically observance. Okay, cross-sectional are used mainly for differential diagnosis studies. Okay, yes, when you're observing something at one point in time, those are cross-sectional studies. You have your case series and case reports, and you have your expert opinion. Okay, somebody put a question in the group that said clinical practice guidelines, right, as being the top one. I don't know who it was. Somebody posted that question in the group regarding clinical practice guidelines. Okay, what are CPRs? CPRs are your highest, like what happens is even these systemic reviews, they are also combined. Okay, it's like a thing that we do, like they are clinical practice guidelines. So based on, like, let's say today you want to determine what do you do for a neck patient? How do we classify them? How do we treat them? You can just Google clinical practice guidelines for neck pain. You will get a thing where it's the most recent evidence of neck pain. So you can treat your patient based on that intervention. So those are your clinical practice guidelines. When you give advanced, like when you passed the NPT, you're working in a setting and everything, and then you decide to do your OCS examination or something, that's when we need to read up these clinical practice guidelines to know the most recent evidence. Okay, you cannot say better than, you can say better than systemic reviews in terms of identifying an intervention for a treatment. So they don't have like everything mentioned. It's just basically how to identify the best intervention based on a particular type of patient. That will be your clinical practice guidelines. Okay, in your NPT, they don't really ask you about different CPRs, clinical practice guidelines, but yes, clinical practice guidelines is just a compilation of your intervention evidences, what to do for a patient. Okay. All right. So that is it for research today. What I want you all to do as a homework is please, okay. 1 minute. There was a question this week in the group and Priyam said we will discuss in the research class. I don't know who it was. Betul, we can, if somebody can post it, we can discuss it in the next class. Okay. We can discuss it in the next class because that one is not based on, I remember Pasha's question, it's based on ANOVA and COVA. We've not yet done it. We've not yet covered it. So we are going to do it in the next class. So we will discuss that question in the next class. Another thing, please, for next class, I want you all to do this homework because otherwise the class is going to go very slow and we won't finish research in 3 hours. Okay. So your homework is to memorize the tests that we use, t-test, chi-square, nominal, ordinal, to memorize those tests. When do we use what? Okay. I will explain it. It will be a revision, but you do your homework and come what tests we use, what is parametric, what is non-parametric, what are the tests used for 2 groups. Okay. If I have something, I will share with you, but I want you all to read up on that and come so that the class becomes easier. Next class, we're going to be doing how to identify which is the best test for 2 groups, 3 groups. We're going to do some practice questions on it. Okay, yes, you can use Dr. Singh's class. I will send something that I have. And we'll also identify how to identify statistical significance, p-values, types of errors. All of that is going to be in the next class. Okay, so next class is going to be a little advanced. Great. So I'm going to see y'all. Okay, please review this lecture again and make notes of it. You still have few days. Don't ignore research. Make research your strong suit. Okay. Yes, I purposely did not do it tomorrow because I want you all to be thorough with the base before I take up the next one. So I will take up the next one on Tuesday and next week we will have 3 classes. Okay, because I don't want to extend it till 1 day before the exam. You all are very welcome. Just go, take a break, take a power nap, eat something, and then log in for the next class. Okay. You all are most welcome. I really hope this was helpful. All right. Class today, system interactions. Bye.